Hi everyone, this is Olivia and welcome to my second patient presentation. I did this presentation on a 76-year-old female who I was actually able to visit for her original nutrition assessment and then perform a diabetes education on with one of the dietitians, and then we were able to follow up with her a few days later. So this note will include both her original assessment and her follow-up assessment. So what originally brought her in was that she presented to the ED from the wound care center due to a chronic right hip wound with right lower extremity cellulitis, and then endocrinology was consulted for uncontrolled diabetes. When we followed up with her 3 days later, per the endo note, the patient was continuing with fasting and intermittent postprandial hyperglycemia despite an increase in basal and prandial insulin, and no hypoglycemia was noted. For her past medical history, it includes a chronic right hip wound, MRSA, chronic pain, a history of a deep venous thromboembolism, hypothyroidism, hyperlipidemia, GERD, spinal stenosis, type 2 diabetes, hypertension, and obesity. Her surgical history includes a hysterectomy, a glossectomy, an appendectomy, right hip surgery, and then a lumbar laminectomy. For her inpatient medications, she is taking vitamin C, Lipitor, Teflaro, furosemide, gabapentin, heparin, hydrochlorothiazide, insulin glargine, insulin lispro, levothyroxine, lisinopril, potassium chloride, zinc sulfate, Zoloft, and then a multivitamin. For her PRN medications, she's taking acetaminophen and acetaminophen hydrocodone, baclofen, Zofran, Miralax, and Senokot. So there are some drug-nutrient interactions with a few of those different drugs. The first one is Lipitor in grapefruit juice, and concurrent use may result in increased bioavailability of Lipitor. The second one is heparin with two different foods. So the first one is avocado, and concurrent use may result in reduced anticoagulant effectiveness. And the second drug-nutrient interaction with heparin is celery, and concurrent use may result in increased risk of bleeding. The third drug-nutrient interaction is levothyroxine with soy, and concurrent use may result in decreased effectiveness of the levothyroxine. The fourth one is sertraline in grapefruit juice, so concurrent use may result in elevated Zoloft serum concentrations and an increased risk of adverse side effects. And then the final drug-nutrient interaction is zinc sulfate with food in general and caffeine, and concurrent use may result in decreased zinc concentration. So the patient has no known allergies. For her diet order while she's in the hospital, she is on a high consistent carbohydrate diet, meaning that she gets 75 grams of carbs per meal. She was ordered a Glucerna shake BID after her original nutrition assessment, and her intake was good. For her anthropometrics, her height is 162.5 centimeters. Her weight upon admission was 86.2 kilograms. Her ideal weight is 54.5 kilograms, so her percent ideal body weight is 158%. Her BMI is 32.6, so she does classify as obese. Because of that, we used her adjusted body weight of 62.4 kilograms to calculate her nutrition needs. So for kcals, we use a range of 25 to 30 kcals per kilograms, meaning that she's getting 1,560 to 1,872 calories per day. For protein, we use a range of 1.2 to 1.5 grams per kilogram, so she should receive 75 to 94 grams of protein. And then for fluid, we use 25 milliliters per kilogram, so she should receive 1,560 milliliters of fluid per day. A nutrition-focused physical exam was not performed. For edema assessed by nursing, she does have pedal edema, so in her left foot it's at 1 and in her right foot it's at 2. So she does have non-pitting generalized edema. The patient was alert and oriented and was in no acute distress. Her behavior was appropriate and cooperative. She did appear obese. Her last bowel movement was the day of her follow-up. As for her skin, she does have the right hip wound. She does have cellulitis in her right lower leg. And then she does have a right posterior calf wound. For her labs, her capillary blood glucose was 196 milligrams per deciliter, so it was high. Her glucose was 160 milligrams per deciliter. And then her BUN was low at 6 milligrams per deciliter. And then her A1C was very elevated at 10.7%. We did place the patient at a moderate nutrition risk. So when we first visited her, it was for a length of stay and a diabetes education. She was on the high consistent carbohydrate diet per endo's request, and she was consuming 50 to 100% of her meals. She reported that her appetite while in the hospital was good. Prior to admission, her appetite was good, and she was usually eating 2 times per day, and she does not follow a special diet at home. We did provide diabetes education during the initial visit, and we talked about food groups, meal planning, carb counting, and label reading. We did provide her with written materials from the nutrition care manual, and then we also provided her with outpatient nutrition counseling information. We do expect good compliance. She was very receptive to the nutrition education, and we recommended a follow-up with an outpatient RDN. The patient had no idea if she experienced any recent weight changes, and she wasn't even sure what her usual body weight is. She denied any nausea, vomiting, or constipation. She did report some diarrhea, and it was noted in her chart that she had two bowel movements the day before and then 1 that day. She denies any chewing or swallowing problems, and then we did recommend Glucerna BID due to her decreased intake. Her capillary blood glucoses were ranging from 142 to 299, and endocrinology was following that. Like I stated before, her A1C was 10.7%, so very elevated. And then just back in August of this year, it was at 6.9%, which indicates very uncontrolled diabetes over the last few months. So we just wanted to encourage PO intake and then keep following her. When we visited her for her follow-up a few days later, she was still on the high consistent carbohydrate diet and stated that she was tolerating it. Since we last visited her, she was eating 75 to 100% of her meals and stated that her appetite is good, so her intake did increase. She was currently receiving the Glucerna shake BID and reported that she was drinking all of it. She denied any nausea, vomiting, constipation, or diarrhea, and also denied any chewing or swallowing problems. Like I said before, her last bowel movement was that morning. She did have some clarification questions about her diabetes education that we provided before, and I was able to answer those questions for her. And then this time around, her capillary blood glucoses were ranging from 109 to 227. Endocrinology was still following, but she was improving her capillary blood glucoses. So then we just wanted to keep encouraging PO intake and then keep following her while she's admitted. So we did diagnose her with a couple of different nutrition problems. So the first one was altered nutrition-related lab values. related to food and nutrition-related knowledge deficit and type 2 diabetes, as evidenced by blood glucose and A1C values. And then the second problem was increased protein needs related to increased nutritional demands related to healing, as evidenced by presence of wounds. For her goals, the first one is we want to improve skin integrity, and we want to achieve that within 7 days. And then the second one was increase oral intake to 75% or greater of meals and supplements, and we want to achieve that within 5 days. So the patient is obese due to her BMI being over 30. No malnutrition was diagnosed during this visit. We do want to monitor the patient for diet and supplement tolerance, oral intake, lab results, and wound healing. For interventions, we provided education. We provided diabetes education. And we want to encourage PO intake, provide her with oral supplements, and then keep following her during her stay. And then for discharge needs, we want her to see an outpatient dietitian for outpatient education. So we want to continue with her current nutrition therapy while she's in the hospital. And then we do want to get a referral from the physician for her to see an outpatient dietitian for reinforcement of diabetes education post-discharge. And because she is at a moderate risk, we will follow up with her in 5 days. All right, thank you for listening.